very much, Victoria, and also thank you very much, Julie Marie, for hosting this event and also inviting me to be the moderator. Good afternoon and good evening, and to everybody, as well as good morning to Graham in Sydney. So chronic diseases are broadly defined as conditions that last 1 year or more and require ongoing medical attention or limit activities of daily living or both. So according to the WHO, the major chronic diseases that cause the bulk of the morbidity and mortality worldwide are cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes. And these 4 groups of diseases account for 33 million deaths annually. This is double the number of deaths from infectious diseases like HIV, TB, and malaria, maternal and perinatal conditions, and nutritional deficiencies. Furthermore, 80% of chronic disease deaths occur in low and middle income countries where most of you work, and half of them are women. And what is equally devastating is that the burden of disease results in massive losses in productivity as well as an undue strain on the already overstretched healthcare systems. So this growing burden of chronic disease globally spurred the UN to set SDG target 3.4 to reduce premature mortality from NCDs by 1/3 by 2030. So today's pillar talk is focused on challenges to addressing interventions for chronic diseases in low and middle income countries. And there are 3 challenges that we're going to be focused on in today's webinar. First is access to life-saving medicines and diagnostics. Second is equitable access to medicines and interventions. And lastly, sustainability, since chronic conditions and chronic diseases by definition require long, if not lifelong, interventions. As we can imagine, each of these topics can each be an all-day discussion, so we are definitely being a little bit ambitious in thinking that we're going to be able to touch on, albeit a high level, on these topics in this 1-hour webinar. So without further ado, I am going to introduce the panelists. We have with us Amanda Fowler, who is the Executive Director of Global Corporate Giving at Edwards Life Sciences Foundation. Brian Murphy-Eustace, Vice President of Programs at the Max Foundation, and Graham Ogle, Co-founder and General Manager of Life for a Child and Adjunct Professor at the University of Sydney. These 3 panelists have decades of experience in humanitarian health, and they're going to make us smarter about the strategies around chronic diseases and interventions in the developing world. I am not going to go through their long list of accomplishments, but their full bios are posted on the PQMD website, and Victoria will be putting that link in the chat box. And I encourage all of you to visit the website for the bios of the panelists. I would like to start by inviting the panelists to just give a brief overview of their organizations, their work, just to set the stage and provide the context as to how their organization's work and experience will contribute to today's conversation. So Graham, can I please ask you to kick off the overview for Life of a Child?
Sure. Thank you, Bill, and thank you, PQMD, for the invitation to talk to you. So Life for a Child is based in Sydney, Australia, and the program has the vision that no child should die of diabetes. And this is particularly apt. This is this year and January next year is the centenary of the discovery of insulin in Toronto, and yet there's still children dying around the world from lack of access to insulin and other components of care. So our program has the mission to support existing diabetes centers in less resourced countries with supplies, technical advice, and training so they can provide the best possible care given local circumstances to young people with diabetes. We also do a lot of work in sustainability in country and do extensive research in access, epidemiology, and outcomes. Currently, we're supporting over 26,000 children and youth in 47 countries. And I think briefly, we're talking about successes and challenges. I think successes would include the rapid increase in numbers of young people alive with diabetes in these countries and improvements in the level of care. The challenges include the fact that insulin is not enough. There's a whole package needed. Blood glucose monitoring is also needed, diabetes education, and skilled healthcare professionals who are skilled in diabetes. And that even when governments do start to help, there's often not equality, not equity and access to care. Thank you.
Great. Thank you, Graham. Amanda, can I ask you to go next?
We can't hear you, Amanda.
We can't hear you. No. I heard you earlier. Maybe we'll go ahead and have Brian. Yeah,
Sure. I can kick off, but what I would say is, Amanda, keep trying to jump in and speak so that if we can hear you, then I'll just pause and turn it right over to you. But yeah, thanks so much, Bill, and thanks to everybody for joining this discussion. I think it's a really exciting one, and one that I'm really excited to be a part of. So I work for the Max Foundation, and so we're a global health nonprofit. We're based here where I am in Seattle, but really we have global teams around the world, and we work to support sort of a unique donation access model, a unique delivery model of medication to tens of thousands of patients in over 70 low and middle income countries. So essentially, where patients are diagnosed with an illness where they have no access to that medication that's critical for their treatment, we work to partner with pharmaceutical companies to get the medication and deliver it to the patients. In addition to ensuring that the medication gets to the patients, we also do comprehensive support, supporting the social determinants of health that patients face in order to move toward health, as well as thinking about the ways in which we can help strengthen the health system and bolster it through whether it's patient and physician education, whether it's diagnostic infrastructure and capacities within the governments and public institutions, or whether it is thinking through other supply chain or mechanisms for facilitating treatment. You know, access is critical and central to our focus. Our goal is a world where we can help accelerate health equity through our programs, and where people are able to face their disease with dignity and hope, regardless of their geography. I would pass it over back to you, Bill or Amanda, but I'm not sure.
Thanks.
Yeah.
Amanda, are you able to get back on?
I think behind the scenes, they're working to try and get her back on.
Okay.
So hopefully.
Nope. Okay, we'll wait for, if you bear with us, we'll wait for a few minutes for Amanda to use her phone to call in.
Maybe, Bill, it's okay to keep going, and then once Amanda can get in, we'll turn the floor back.
Can you hear me now?
Oh, perfect.
Yes. Oh, perfect.
Okay. Is there a feedback?
A little bit of a feedback.
Well,
Ooh.
about that.
So maybe what we will do is go ahead and kick off. Brian, you talked a little bit about access and medicines and diagnostics. Would like you to delve perhaps a little bit deeper into the issues in what makes for successful donation, and how you maintain that donation, and what are the critical factors to ensuring successful donations and the challenges also.
Yeah, thanks, Bill. And it's such a a difficult question because there's so many elements. I think that all of you probably even better than I know, sort of face a quality donation program. One of the things that I constantly come back to is sort of the, and particularly right now in light of what we're seeing with sort of COVID and treatment and vaccination distribution, is the sort of common misnomer that availability equals accessibility, right? Like one of the real challenges that we find in our programs is that we support patients where there's no access at all within their country. And so truly there's just no other either commercial pathway or public pathway. But one of the things that we're seeing is that even in countries where there might be some element of availability, whether it's through certain programs, that doesn't mean that it's really reaching the end patient. And so one of the critical components that I think we've really focused on within what we call the max access solutions model is thinking about really placing the patient at the center and ensuring that we're able to really track patient outcomes. That's obviously, particularly as it relates to this pillar talk, really, I think critical because the component of sort of chronic care delivery is a bit different than treating sort of acute illness, right? You really have to have longitudinal tracking to be able to understand a whole host of events, whether it's adherence monitoring or monitoring for adverse events over time, or whether it's around resistance issues as patients might progress in their illness from one treatment to another. And so to really be able to do individualized patient tracking and ensure that the medication is reaching the end user on a consistent basis, and that is also being and other elements of their needs are being addressed to ensure that there is that consistent delivery, I think is hypercritical. With that, of course, brings a whole host of other challenges, right? COVID, again, is just a wonderful pressure tester and has been for us, where things like last mile delivery logistics to patients, or things like transportation assistance for patients so that they're able to go to the clinic and have regular appointments to then be getting prescription refills and distributions and dispensing. So I think, for us, a core sort of a lighthouse has been just focusing on what the patient needs holistically to ensure health, and then having the donation program conform to those needs and have that be tailored and flexible and individualized to the local realities that patient faces.
Thanks, Brian.
Bill, this is Amanda. Can you hear me now?
Yes, perfect.
I'm sorry, that was awkward because earlier I had joined and it was all just fine. I would love to jump in if you don't mind. That makes sense.
Please.
So this conversation is really important to us in the work that we do. So I have, I think, the honor of serving Edwards Life Sciences, overseeing all of our global giving. So half of our giving is really focused on cash donations, and the other half is really is bringing access to and equity, frankly, to the products and technologies that we provide and all around the world to our commercial patients, and really bringing that to the humanitarian world is what I've been very focused on. And we are a technology company focused on heart valves and critical care technologies. And heart disease is the #1 cause of death in the world, and it is a chronic disease. And right now, it is all of these patients that have other diseases besides the sort of highlight of the show at the moment, which is COVID. And no doubt, all the other patients are suffering because of it. Hospitals, as everybody knows, are full of COVID patients, and these sometimes seeming almost optional treatments for chronic care is really getting sidelined. And so our team is spending honestly every day fighting for these patients so that they aren't sidelined. And it really takes commitment, and it takes a long-term view, ideally, so that we're bringing sustainable solutions, working closely with ministries of health. And I really respect, Brian, your point that access does not mean equity, or equity does not mean access. It's a really important point, and I think a lot of us are working on those patients who are the most challenging to reach and finding new ways to help them. And how do we do more than just give them the handout? How do you really create long-term solutions and bring long-term care, especially right now in this moment for chronic diseases? It's just a challenge. So I'm looking forward to learning as well as sharing what we're experiencing in the most difficult environments around the world.
Great, thanks, Amanda. So Graham, you heard Brian and Amanda both talk about direct access to patients. And of course, Life for a Child works directly with patients too. However, I think that for those that have worked with programs that involve children, you actually have an additional hurdle to go through, which is because you actually work with the patient through their parents. Can you provide some insight as to maybe some common factors of success, critical factors of success for working in the children environment and the specific challenges too? You're on mute, Graham.
That's an interesting question. I think a lot of people, including a lot of doctors, think that children are little adults and you can just treat them as little adults, and they're not, as any of us do remember when we were children, or those of us who have children soon learn. And so the health professionals need to understand that the child's mind is different, that the adolescent mind is different, and to be able to connect with both as a clinician, you have to connect both with the parent and the child. And you do have the situation sometimes where there's a lack of formal education for the parent, and if the child is too small to be fully educated themselves or to be competent literate themselves, then they have problems as a family understanding and instructions. But on the other hand, we see families who have very limited education, formal education, who do very well just through dedication. And so I think essentially you need staff in the country partners that you're working with who have the empathy and the skills to look after these young people. And when they do that, when they have the dedication, you could call it love if you like, the passion to help, then it can work. But it does add, as you say, it does add another dimension to the difficulties in caring for children.
Thank you, Graham. Going back to you, Amanda, on a couple of things you said regarding, I guess, state-of-the-art technologies and top-of-the-line treatment regimens. From the Edwards Life Sciences perspective, how do you manage that and reconcile that with the fact that you have commercial interests in where you develop it and where you register the product, and then trying to get the same product in the humanitarian context?
Well, the great news is that we work with a partner that I'm sure many of you work with, MAP International. And by working with MAP, that's a humanitarian organization, they are actually able to bring the newest technology into countries that really fall under humanitarian exemption. And it frankly is a much more sophisticated and streamlined approach. We used to do the donations ourselves, and I'm sure, like many other of my peers in the corporate side, we would need to ensure that the product is registered in every country before bringing the product in, and trying to do that work in Ghana or in Sudan or in places where we simply, it's not a commercial interest. It really took a significant amount of internal resources, and our passion for it was high. and our resources and time and commitment we could spend on it was low. So we've really found an excellent partnership in MAP International and are able to work through some of those regulatory requirements. Now, the bigger question I think here is for those of us that really are providers of the highest level technology to treat patients. For us, it's the transcatheter heart valve, which is tends to be a very expensive product in itself with the price tag. Although in developed regions, when you put it together with the total cost of all of the treatment, it actually is a very cost-effective solution for the patient because you are in and out of the hospital perhaps in a day versus open heart surgery that might be longer. And if you ask me, also thinking about a quicker hospital stay for a patient in, say, Africa or deep China or you name it, wherever else we're working, there is also an added benefit of less risk of infection and other diseases that could be there. And frankly, in this moment, more hospital bed turnover for COVID patients, which is a significant priority in many regions. So the challenge that we are up against is when you bring, I'm going to call it, and I don't really mean it this way, but if you bring a Rolls Royce into Africa, the perception might be that it's not sustainable and it's not really a long-term solution if the patients in that country aren't able to purchase that type of a product, or if the ministries of health aren't really buying into that. So I really think what it takes is long-term partnerships with ministries of health and government entities. And I think it also takes a partnership with healthcare economics and really proving the value of treating patients earlier in their lives and bringing them to a healthy state versus managing chronic disease over the long term and the value that brings. So I think it really takes long commitment. And I suppose medium term might be a better, more palatable conversation for all of us. But it definitely is something that we grapple with. And a lot of times what we see actually in the humanitarian world is almost the selection of the least expensive technology, which I think over time actually ends up perhaps costing more and also not necessarily solving the problem. So I think it's one that, frankly, I'd love to learn more from others and what they're doing with the highest technology that they are using for patients and helping
to. That's a good lead-in. Yeah, that's a great lead-in for a question, I think, to Brian, as those that are suffering from cancer. There are, the whole cancer treatment field is very, very dynamic. And so Brian, what are your perspectives from a recipient base?
No, I think it is a wonderful topic, and I really appreciate Amanda's perspective on that, because I couldn't agree more. I think that often, the world of oncology is changing rapidly, as you suggest, Bill, and I think we're seeing new treatments, innovative therapies come out every month, that feels like at this point, let alone every year. And what we've seen in the progression of equitable access is that initially those medications are made available, right, in high income countries and are commercialized in very few. Meanwhile, there's patients that are suffering from the exact same illnesses that, if you believe as I do, that, health is a human right and all of those patients deserve access. Right now is the time to be thinking, well, what is the pathways for access models that could ensure global wide access to these innovative therapies that are now available? And so, I think that I think it's something that we're really focused on partnering with these companies to say, how there are ways to treat these illnesses all over the world, and that we could be a mechanism and a pathway to supporting the way in which these medications could be delivered and safely used for patients in these countries. One of the things that I think is always gets kind of confounded in the conversations around what is the right access model and around sustainability is sort of the false dichotomy that gets presented on whether, should it be a commercial pathway? Should it be a public sector procurement solution? Should it be generic drugs that are then sort of shared throughout the world, as if it's really not, the solution is not to have all of these things, right? Even in a high income country like the US, where the COVID vaccine is massively available, we see huge swaths of the population not accessing a life-saving treatment, right? So I just think that, I guess a death-preventing treatment. So I think that one of the things we need to do is not to kind of reject the idea that we need to pit one model against the other, and really understand what are the ways to sort of bring a whole cadre of solutions at the same time to create broad access for different segments of the population that fall within different areas. High income people procure it on the private sector, commercial markets, middle income that's on Social Security, people that aren't even able to access social safety nets, that's a donation strategy. And so that's just something that we're thinking a lot about, how to better articulate that and share that. Just last comment, I think an analogy that I've started to think through is it's kind of like seeing a house on fire and saying, well, is the right solution to improve the water grid, or have better building codes, or more fire stations, or better trained firefighters, or should we put out the fire with the water, donated water right now? And the answer, of course, is all of them. We shouldn't not strengthen the building code, not fix the water grid, but for the house that's on fire, we should put it out today. And so there's no patient saying, I don't want that medication because it's donated and that's not sustainable. They're saying, I need the medication. Let's get the medication there.
Thanks, Brian. While we're on this topic of access, and also in the interest of time, I think we can spend a lot of time here, but I'd like to actually move over to Graham. Graham, you indicated earlier that yes, insulin may be accessible, but there is not enough of it. Right? So if, let's say, you are in a situation where you have the insulin and it's not enough to cover everybody in the country or in a particular program, how do you manage equity? Moving on to equity question, how do you manage equitable access to your limited supplies?
Well, yeah, it is tricky. I think from an external viewpoint, what our program supports young people up until the age of 25, and we have sort of partial solutions beyond that, which I don't have time to go into, but we are a program focused on youth, and an analogy in the US, I think a lot of health insurance programs go up to the age of 25 for children. And so we do have to have a cutoff. It's painful, but we do. I think largely we leave it up to our partners to decide. They're on the ground, and they're usually the National Hospital or the National Diabetes Association, and they distribute the supplies according to how they see fit. Sometimes there's a formal means testing process that happens, sometimes not. I think for countries where the government can't afford to buy all the insulin that it needs, the fact that we can provide insulin for young people with type 1 who will quickly die without it anyway, does help the overall situation. Of course, in the end, you want to move towards sustainability. And with some countries, we have been able to wean the amount of insulin that we've sent. And a couple of countries, we've been able to stop sending insulin because the government now provides adequate insulin for the whole country. And in at least in a couple of countries, the work that we've done has actually stimulated the government to do that. And so I think in summary, we do leave it to the local partners to judge where the insulin should go and who needs and who doesn't. Of course, that process is open to bias or manipulation if you have the wrong partners. But on the whole, I think that doesn't seem to happen. You find the right people and you work with them, and they're people who want to help, and they do. But it is, I think there's further issues though in terms of getting insulin and getting supplies to those who are most disadvantaged, and maybe we can talk about that as a separate question.
Wouldn't mind
Amanda.
that if you don't mind. I think
Yeah.
it's really interesting. We're thinking a lot about it really feels like the topic du jour also, except for COVID, across corporate America, which is diversity, inclusion, and belonging. And where we're really stepping in and taking a look also is that equity piece, and thinking deeper beyond just who are the people making decisions, but also thinking about how are we making the opportunities available. And I think it is communication, I think, is one of the greatest barriers. And while many of us believe globally the language to operate in is English, or the native language for some of maybe the 8 of the world's most commonly used languages. But if you really want to bring equity, that awareness needs to be there for, Graham, in your case, the families, and of course the children. And I think that's can be a huge equity piece that we all need to be thinking about. I also wonder if you cut out a little bit of bias by funding many partners instead of, perhaps just working with one. There's a long conversation. Do you go long and very deep with 1 or 2 big partners, or do you have many different partners covering all different angles and different pathways? We've really chosen to work with 60 partners with our signature charitable initiative that's focused on heart valve disease. And I really feel like that might be a way that helps cut out some bias, because you have many different perspectives coming to the table. And we bring this community together at annual forums in person way back when, or in conference calls. And we really put all of the partners together to talk through their issues and to share ideas and to break through potential barriers and solve, fill in gaps with others' strengths. And I feel like that has been successful for us, and perhaps is a way to address that bias and equity piece that we're all thinking about a bit more. It takes more work, and, of course, pros and cons with working with many versus a few.
Thanks, Amanda. So Brian, I saw you nodding your head, and also, with the Max Foundation, working in 70 different countries. Can I ask you to maybe summarize and close out the equity conversation before we move on to sustainability?
Yeah, sure. One of the things I was really nodding my head about was actually what Graham just shared around it was really interesting to hear you, Graham, say that the government has started to procure at a deeper level in certain situations that you've seen because of your donation program, right? And it's just it's a story I've not only heard but seen so many times that I just think we're not doing a good enough job capturing and sharing broadly. And for others in this conversation and on this call, I'd love to be hearing more of that and thinking about the way that we best articulate that. In our programs, there's just so many countless examples of similar to what Graham shared, where we see that, through the work that we're doing in a donation program, it leads to broader patient advocacy that then leads to more increased government investment and intervention, or to a quicker drug registration for long-term commercial viability, or it leads to more diagnostics infrastructure that creates more diagnoses of the same illnesses, that then creates a greater patient population, that creates more pressure on the government. So there's just countless examples, to say nothing of a country where we might work where there's one hematologist, and now they have the actual medications to do the work that they've been trained to do, that then leads to more hematologists or oncologists wanting to join in that work in that field. And so I would love to see us find ways to articulate that, because I think just on that equity conversation, often we're thinking that by providing that it's one or the other, right? Like if you're doing donation, it might take away from commercial viability, or might take away from a government's willingness to procure the medication for its population. And in fact, we're not seeing that at all. I'm not seeing that at all. I'm hearing that from people like Graham, that they're not seeing that, but quite the opposite. And this is almost a call to everyone to be thinking about how we're sharing that message more clearly.
Right. Thanks, Brian. I guess, one of the mantras when I was working for J&J is that donation is not a global health solution. So
Right.
Coming back to the conversation with the three of you, it is certainly very refreshing to hear how donations are actually moving the needle on a lot of these diseases. So while so now that we are moving on to the sustainability question, this is the last topic we're going to discuss, and considering, of course, chronic diseases being requiring interventions, diagnostics, and treatments that are lifelong. There are a lot of donors and organizations. So how do you decide when to stop, etc.? So I'd like to actually start with Amanda, as even though I think in some ways Edwards Life Sciences being a devices company versus a medicines and consumable company might be a little bit different, because it's not like the patient needs the intervention lifelong. They have a heart valve, and then anyway,
His volume.
I would like you to share your perspectives from the private sector regarding, how you decide how long to donate a medicine once you've made a commitment, and if there is an end game in the equation for your donations, how does the private sector devise the strategy for viable and ethical exit?
So I do think it might be eye-opening to many people that in the developing world, rheumatic heart disease is really a disease of teenagers and young adults. And if you go even younger, congenital heart disease is often a disease of fixing the structure of a heart at a young age, as early as maybe a month or even newborn. And so what we do see, interestingly, to your point, Bill, is those we do invest in and support programs that treat congenital heart defects at infancy all the way up through seniors. And I'd say in the developing world, we more spend our time on pediatric, and I would say the maybe below 30. And what we know about those patients is they do get one treatment, which is a pretty significant experience with open heart surgery, and they will in their lifetime need another surgery. The holy grail, of course, for heart valve replacement is a valve that will last forever. And while we've made amazing advancements and not requiring open heart surgery and being able to take that same heart valve and replace it via catheter, where you're out and back to your life in a day, and those can be put valve inside a valve if you need replacement over time. I do believe that the long-term strategy for us will be bringing that highest level of technology to these patients, where they can perhaps even it's more relevant for them to have the transcatheter technology, to have that highest level where they don't have such an invasive procedure, and where you are committing to, over the long term, procedures that are better for them. Now, what that means, of course, is a long-term commitment. And I do believe that's where we as a corporation are showing up, and I see it all across with my peers and many on the phone, showing up with a long-term mindset. And what will be important for us is that we are partnering with organizations that also have a long-term mindset or medium-term. And critical to that also is that the healthcare centers they're working in have a bit of skin in the game. And while we really started off thinking all of the healthcare needs to be pro bono and everyone needs to do everything philanthropically. I just don't know that, to your point, philanthropy is perhaps not the solution. And so getting everyone to have a little bit of skin in the game is important at the onset, having clear, measurable goals. So you do know what success looks like when you start a program. And you, in 10 years or 15, 20 years, when you look back, you can, and you see you have achieved that, that was your endpoint and it's time to call that success. And we've had a few partners that we've been funding for decades that have declared success, setting up pediatric cardiac surgery, for example. In Russia, they went from having no availability whatsoever to training the locals to treat the locals, and then having 5 or 6 centers there, and now going to the next change-ready country or region that's really ready to put skin in the game, and they've moved on to Latin America. So I think all of those pieces, the most important is skin in the game by everyone.
Great. Thanks, Amanda. Graham, you also, I guess, talked about earlier about getting governments buy-in so that they at least take over a portion of the program. Can you elaborate a little bit more on that regarding how you successfully get that accomplished and move things towards more of a sustainable model versus a long-term commitment?
Sure, and I apologize for my phone. It was on mute, but I haven't worked out how to stop it invading my Apple when I'm on Zoom. So I think there's a couple of aspects to this for us. We realized, or we were evaluated by the London School of Hygiene and Tropical Medicine, an independent evaluation a few years ago, and they said 3 things. They said it was a good program, that was doing what it should be doing, that we needed to do more with sustainability, and that we had access to a lot of data, and if we use that data properly, it could be a global public good. And so we've really dived into the data, and I think that helps to determine the numbers of young people who have the problem in the country, and the numbers that should be alive. So modeling work to determine, well, where are they? They're not there. They must be dead. But looking at the disparity in those sets of numbers, and then looking at numbers in cities versus rural areas and the disparity there, and putting that information together really does strengthen advocacy. And then I think, as has been said by Brian and Amanda, just getting the people that we work with start to get empowered, and you end up with more hematologists or pediatric endocrinologists or whatever, and that process happens, and then they often have connections, and some of them are good advocates, and to empower the diabetes the lay associations in particular with advocacy tools is very powerful. And you mentioned that at the start that we all feel about people with, we all feel more about children, if you like, that there's a lot of empathy around children and young people. And so we've also been working on the aspect of that health is a human right. And we've had a webinar with African young Africans involved in human rights in diabetes and other chronic diseases, and that will lead to other initiatives with scholarships, and for young people to be able to front up and to politicians in an arranged setting and present their case, it is powerful, and it empowers them. It encourages them to be even more bold the next time. And some of the politicians listen, some don't, of course, and some do listen and say they'll do something, and then nothing happens, of course. That's also very common. But sometimes something happens. And then once it happens, once some insulin or more insulin is being provided, once the government starts buying test strips, that can grow. And we're also most recently working with a group called FIND, the Foundation for Innovative New Diagnostics in Switzerland, on a process where companies that provide these supplies are contacted, and then there's negotiations with them about price, and that then can be passed on to the government. And there's other groups working in the diabetes space as well, the Access Initiative and others that are doing this as well in different ways. So I think that there's many ways of starting to put pressure on governments, and part of that is information, part of that is advocacy, part of that is just determination and patience.
Right. Thanks, Graham. In the interest of time, Brian, can I ask you to maybe give a, since you haven't really commented on the sustainability piece, can I ask you to maybe in 1 minute, 90 seconds or so, summarize your thoughts and perspectives on sustainability so that we have a little bit of time for some questions from the audience, because I see a lot of chat coming in and I'd like to give them an opportunity.
Sure, yeah. I mean, I guess briefly, I would share that like I said earlier, sort of, I rage against this idea of the false dichotomy that, like, donation program, you have to choose one or the other. That being said, I deeply believe that long-term sustainability should become a transition away from donations into all of the other pathways of access, because with the understanding that there'll always be a subset of a population, even in the United States, that find it really difficult to access care reliably, and that concern still needs to be met. But that aside, so in our programs, we have transitioned full countries away from donations of our treatments to the public sector and private sector systems, because as Amanda shared, over 10, 20 years, these countries that started out as low-income countries are now middle-income countries, have robust systems, and those drugs are now available in a variety of other pathways. And so our work is no longer needed. And so that's the way we do it. Of course, it has to be done very carefully and thoughtfully, but we transitioned full country programs away from our program, the Max Access Solution model, to the government and private sectors. So I think it's important. I think it needs to be done, and it's the right strategy. The one thing I would just caution is, for certain countries, that pathway is super long. I spent years working and living in Liberia, where they spend $45 per capita on their health expenditure, versus the United States, where we spend $12,000 per person on health. And these are in Liberia, it wasn't that it wasn't spending a large portion of its GDP. It was spending 10% of its GDP, similar to the same amount Australia spends on its health expenditure of their GDP. And so really, we just need to be realistic, I think, about what that timeline looks like for countries, and still be asking, well, for patients in these countries, in Liberia, that have only $45 per person to spend on their healthcare, what are we doing in terms of other economics and other programs that would ensure equitable access globally? And that's all.
Great. Thanks, Brian. Victoria, since I haven't been keeping track of the chat, I just see little things pop up. Would you like to maybe help manage the audience questions?
Sure. I'll start with one from Steve from Heart to Heart. He has a two-part question. The first says, how does your organization company decide where you should work? And then the second part of the question says, it has been mentioned that governments eventually choose to support. Is government receptivity involvement a factor up front in deciding where you work?
Is that directed at any particular
I think it's
panelist?
open. I think it's open. So I don't know if anybody wants to grab that one or tackle that one.
I'm happy to. The funder. We really look to work in regions where we can bring more than a checkbook. So that really is part of this conversation, where you can bring dollars and where you can bring your product. And also an important element is bringing, I believe, our employees. And I think they can open up doors, and they can bring more manpower, if you will, and more energy to an initiative. And it could be just pure inspiration, but I think it is a really important element in working in some of the regions where you have a deep connection, where you can really bring that to life. So for us, some of those developing countries where we have a large employee presence would be Brazil, India, China, and as well as the Caribbean. Of course, we do a lot of work in Africa and so forth. A really important part of this is really ensuring that that region is change ready. And we had an excellent partner that went through that transition that I was explaining from Russia to really identifying where to go next. And we've really used some of that research that looks at where there is a strong enough government, where there is enough wealth to, and of course we're talking about all developing countries, but enough money to somewhat sustain, as well as enough infrastructure there. So I'd say some of those, the more successful regions are those that are change ready. And can we also identify some, I think it's along Brian's thinking, is make sure you're looking at all different angles. So also investing in some of those regions where they need a few more steps of investment before they are change ready. So we try to look across all of it. I think we spend majority of our dollars where we think there's going to be the greatest impact now and helping human life right now, which is why we do patient care versus research.
I think that flows really well into the second question, which I think maybe Brian, if you're interested in answering this one, it says, given the time it takes for medication to go from FDA approval to broadly accessible in low and middle income countries, what should be done for patients suffering from the illnesses that this drug treats during this time period?
Yeah, and also just Steve, to answer your question, for us, we just go where it's not, if there's a country where the drug that we have access to is not available any other way, that's where we go. We just don't, if it's already available some other pathway, it's not a country that we would first look at. But yeah, I think also I saw in the chat, Julie Marie, like you much more eloquently put the exact question that I'm really excited about, that also Graham had touched on. So if anybody wants to throw out answers to that, I would love to hear them as well, of how we better tell that message and that story. But yeah, just in terms of that timeline and pathway to when the drug might be commercialized in a country, like what are the mechanisms that we can do to support access today and now? And it's something that we're critically thinking of, and we've really adopted the model that there is a safe and reliable way to take innovative products and bring them to patients all over the world. And you know, I think there's other organizations that have wonderful models that are facilitating that access as well. And of course, all of the other ones that you often hear floated around, between thinking about ways to try to encourage companies to give voluntary licensure, or thinking about pooled procurement where regions can band together and get discretionary pricing for products that might typically be commercialized at a higher cost in other countries, and have tiered pricing. And thinking about, there's lots of issues, of course, with all of these models, but all of them present at least a viable method to accelerate access until that product is fully sort of available, or patients in certain countries could afford it at the current commercial prices.
Great, thank you. I know that we have other questions in the chat, but just for everyone, we will take these to the community of practice. So any questions will not go unanswered, but I wanted to turn it back over to Bill, because I know we have a minute left over, and I think he wanted to say a few words. But I just wanted to thank everybody right now from PQMD for joining us. We greatly appreciate Bill's time, Graham's time, Brian's time, and Amanda's time. As you can see, we were incredibly lucky to get the time and the expertise from all of these individuals to contribute to such a wonderful conversation. And Bill, I'll turn it over to you for the last words.
Great. Well, thank you very much. I want to thank the panelists. You know, I can't even imagine how to summarize the conversation, the rich conversation we had this past hour. But you know, today's conversation, I guess everybody needs to take away is that it is only the tip of the iceberg, and that there's a lot to be done, and there's a huge world out there with a lot of need. And so I encourage all of you to reach out back to the panelists, and we did get permission from the panelists that it is okay for you to reach out to them directly. And as Victoria said, these will be your questions, outstanding questions will be answered. So, and I encourage again all of you to continue the conversation, because who knows what this collaboration will bring moving forward. And lastly, I want to thank PQMD for hosting this Pillar Talk. Thank you, Brian, Graham, Amanda. It's a pleasure being able to moderate this session, and it was a privilege. Thank you very much, and I turn it back over to Julie Marie or EJ or Victoria to close out.
Well, I'll just thank everyone again for joining us. We greatly appreciate the time. We know that there's a lot of webinars these days, but we really hope that you found this to be as educational as I did. And as Bill said, hopefully this will bear some additional fruit. So greatly appreciate everybody's time. And again, especially the panelists and our moderator. It was a wonderful discussion, and thanks for letting us listen in. Thank you, everybody.
Such a pleasure. Thank you all. Yeah,
Bye-bye.
thanks.
Thank you.